Hello, my name's Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we present bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be discussing the assessment of a patient who presents with a transient loss of consciousness. And let's start with a case study. Finn presents as a walk-in to your surgery one afternoon. He's a 27-year-old electrician who is usually fit and well, and he has been brought in by work colleagues because he blacked out at work. He tells you he had been stood up for some time trying to fix a boiler. He felt very lightheaded and his vision went dark. His colleague says that Finn went very pale and passed out. He nearly fell but was caught and they lowered him to sitting. He was noted to have a few brief jerking movements in his arms, but on lying him down fully these stopped and he regained consciousness. He was unconscious for no more than 10 seconds, although it felt much longer to his colleague. He feels quite shaken, but can remember the events leading up to his loss of consciousness, and he recovered quickly with no confusion. Throughout this podcast, we're going to think about the initial assessment of patients such as Finn, who present with a transient loss of consciousness in primary care. We're going to consider the important points that we need to cover in our consultation, as well as the need for any investigations. I will also discuss the referral criteria and some important safety aspects. Transient loss of consciousness is not an uncommon presentation in primary care, and this is because it affects around half of the population in the UK at some point in their lives, and it's responsible for 3% of A&E admissions. Transient loss of consciousness is defined as a state of real or apparent loss of consciousness with loss of awareness. It's characterised by abnormal motor control, loss of responsiveness, and a short duration. There are several reasons why transient loss of consciousness can occur, and these can be grouped into syncopal and non-syncopal causes. Syncope occurs due to cerebral hypoperfusion, when cerebral blood flow ceases for 6 to 8 seconds, or if there is a drop in systolic blood pressure below 60 millimeters of mercury. It typically lasts for under 1 minute and is associated with spontaneous, complete recovery. Syncope most commonly occurs due to reflex or neurally mediated causes, such as vasovagal syncope, and actually this is the commonest reason for a patient presenting to primary care with a transient loss of consciousness. Vasovagal syncope can be orthostatic, when it occurs with standing, or emotional, when it occurs, for example, with pain or at the sight of blood. And actually, reflex syncope is most likely to happen when several triggers occur at the same time. Patients will experience sweating, pallor, and often palpitations. Their blood pressure drops, reducing the cerebral perfusion, and this results in lightheadedness and changes in their hearing and vision. The symptoms improve rapidly on lying down and restoring perfusion to the brain. Episodes often occur in clusters and then might spontaneously improve. It's worth being aware that patients who experience frequent episodes, even if there is no underlying concerning diagnosis, have a significantly reduced quality of life, with a loss of confidence and restriction of activities. Other neurally mediated causes of syncope are situational syncope, when the syncope is clearly and consistently triggered by a specific situation, such as micturition, defecation, swallowing, coughing, or post-exercise, and carotid sinus syndrome, which usually occurs in older men with pre-existing cardiovascular disease. Syncope can also occur because of orthostatic hypotension or cardiac syncope, which is often due to arrhythmias or structural heart defects. Non-syncopal reasons for transient loss of consciousness include epilepsy and rarer causes such as non-epileptic seizures, TIA, subarachnoid hemorrhage, and trauma. So what should we be covering in our initial assessment? Well, one of the main aims of our consultation is to try to differentiate a simple vasovagal or situational syncope from cardiac syncope and non-syncopal causes such as epilepsy that need further assessment and management. A study published in the British Journal of Cardiology in 2017 found that we were very good in general practice about asking about the features that differentiate vasovagal syncope from epilepsy, but not as good about asking about syncopal red flags that would help identify the cardiac causes of syncope that are associated with higher mortality. So we need a detailed description of what happened, and it's helpful, as we did with Finn, to get a collateral history from a witness, as well as to understand what the patient remembers. We should ask about the circumstances of the event. Were they standing or sitting? Was it associated with stress, pain, or fear? Or was there any association with coughing, passing urine or stool, or swallowing? Relationship to exercise is important, as loss of consciousness during exercise can be cardiac-related syncope, and may be the only symptom preceding sudden cardiac death, whereas syncope after exercise is more likely to be neurally mediated. We need to inquire about prodromal symptoms, such as dizziness, sweating, palpitations, or visual changes, as well as the presence of chest pain. We need to understand the patient's appearance and colour, and whether there were any abnormal behaviours or movements, such as incontinence, tongue biting, or limb jerking, and if so, how long they lasted for. Were there any injuries that occurred, either because of falling or due to any abnormal movements? And finally, we need to ask about their recovery. Were they confused? Was there any amnesia or unilateral weakness? Other factors that it's important to cover in the history include asking about any previous events, the patient's past medical history, and for any relevant family history, particularly whether there are any instances of sudden cardiac death in the family under the age of 40. Finally, have a look at the patient's medications, including those that may increase the risk for postural hypertension, such as diuretics. It's also important that we examine our patients. We should check their vital signs, including lying and standing blood pressures, a cardiological examination checking for abnormal heart sounds, as well as signs of heart failure. And we must also examine for any neurological abnormalities. If there is concern about orthostatic hypotension or postural tachycardia syndrome, then we can undertake an active stand test, which is sometimes called the poor man's tilt table test. For this examination, the patient should be lying down and then asked to stand up, ideally with some support available for if the patient starts to feel faint. Their blood pressure and heart rate should be repeatedly recorded while lying and then for 3 to 10 minutes once standing. We should also undertake an ECG, as an abnormal ECG increases the probability of cardiac syncope, and red flags that we need to be looking for on the ECG include any conduction abnormality, including complete right or left bundle branch block or any heart block, a long or short QT interval, evidence of ischemia, inappropriate and persistent bradycardia, atrial or ventricular arrhythmias, including ventricular ectopics, Brugada syndrome or ventricular pre-excitation, left or right ventricular hypertrophy, and a paced rhythm. The need for any other investigations will be based on the patient's history. So if, for example, the patient is diabetic, then we might want to consider a blood glucose. Or if there are concerns about anemia, then it would be appropriate to check a full blood count. Uncomplicated vasovagal syncope can be diagnosed in general practice when the loss of consciousness is associated with the 3 Ps of posture, provoking factors, and prodromal symptoms, in the absence of any features to suggest an alternative diagnosis. It is worth remembering that brief, irregular, jerky limb movements can occur with vasovagal syncope, and this is not necessarily due to epilepsy. And tongue biting can also occur in vasovagal syncope, although in these cases it is usually the tip of the tongue that is bitten, whereas in epilepsy it's usually the lateral tongue. If we're confident in the diagnosis of a vasovagal syncope, then we should discuss the mechanism of the faint with our patient and review their drug history to reduce or remove any culprit medications. We should also give advice on possible trigger events and strategies for avoiding them, including avoiding prolonged standing, heat and alcohol, maintaining a good fluid intake, and considering additional dietary salt unless contraindicated. We can also discuss the importance of regular meals, fibre to prevent straining and defecation syncope, and avoiding heavy meals in postprandial hypotension. Compression such as waist-high tights or compression sports clothing can be helpful for some patients, and medical alert bracelets can also be useful for people who faint regularly. We can reassure our patients that vasovagal syncope is usually associated with a good prognosis, but we should advise patients to present back to us if the episodes recur, especially if they differ from past events. Driving is an important consideration in any patient with transient loss of consciousness, and in relation to road safety, the two most important features are prodrome and posture. For a typical vasovagal syncope, the DVLA does not need to be informed unless the patient holds a Group 2 licence, the syncope occurred while sitting, or if there were insufficient prodromal symptoms to allow the patient to get to a place of safety prior to the loss of consciousness. In these situations, and for all other causes of loss of consciousness, I would encourage you to look at the guidance that is available on the gov.uk website on the page dedicated to assessing fitness to drive in patients with neurological disorders. It gives very helpful and detailed guidance on how long patients should refrain from driving, depending on the licence they hold, whether there has been a single episode or recurrent blackouts, whether the loss of consciousness has been explained, the position of the patient, the presence or absence of prodromal symptoms, triggers or reversible causes, as well as risk factors or findings suspicious for cardiac disease and features of epilepsy. I've put a link to this guidance in the show notes for this podcast. Episodes of uncomplicated vasovagal syncope do not require any further immediate management, and neither do patients who report situational syncope, as long as, again, there are no features to suggest an alternative diagnosis. Patients with cough syncope, however, must inform the DVLA, even if the cough syncope episode occurred during a short-lived period of increased cough, such as an episode of acute respiratory infection, as that person is at higher risk of experiencing an episode of cough syncope whenever they cough, and treatment or resolution of the condition which caused the cough doesn't reduce the risk of syncope with further coughing episodes. For all other patients with transient loss of consciousness, so other than vasovagal or situational syncope, further assessment is required. If there is a history of trauma or findings of a neurological deficit, then obviously an immediate same-day assessment will be required in secondary care. Patients who have had a suspected first epileptic seizure should be referred urgently to neurology to be seen within 2 weeks. Factors that increase the possibility of a seizure include loss of consciousness for more than 5 minutes, amnesia for longer than 5 minutes, injury or tongue biting, incontinence, turning the head to one side during the loss of consciousness or other abnormal posturing, prolonged limb jerking, prodromal déjà vu or jamais vu, or postictal confusion or headache. Patients with suspected seizures should be given safety advice, including, when appropriate, using a shower rather than a bath and not locking the bathroom door. supervised swimming, avoiding working at height or climbing above their height, cooking safely, and caring for babies and young children. There is excellent advice available on the Epilepsy Action website, and I've put a link to this advice in the show notes for this podcast. Patients with a suspected seizure must also be advised not to drive and should inform the DVLA. Now, if postural hypotension is suspected, with a typical history and blood pressures that confirm the diagnosis, then there are very good recommendations in the NICE hypertension guideline for the management of this condition that we can follow. If there is a typical history of postural hypotension, but blood pressures do not confirm the diagnosis, then we should refer to cardiology. Unless the patient has a clear diagnosis of uncomplicated vasovagal syncope, situational syncope, postural hypotension, or suspected epilepsy, they should be referred to cardiology for further assessment. Again, they should be advised not to drive and to inform the DVLA. The urgency of this referral will depend on the clinical situation, but red flags for syncope requiring an urgent cardiology referral include ECG abnormalities, loss of consciousness during exertion, a family history of sudden cardiac death under the age of 40 or an inherited cardiac condition, heart failure or new or unexplained shortness of breath, an undiagnosed heart murmur, patients over the age of 65 with loss of consciousness with no prodromal symptoms, known structural heart disease or coronary artery disease, syncope when lying down, sudden onset of palpitations immediately followed by syncope, or syncope preceded by chest pain, a short prodrome, or unexplained systolic blood pressure below 90, or bradycardia of less than 40. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. And would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to make your lives a little easier and ultimately help improve the lives of our patients in primary care.